Hello students. Welcome again to chapter 20, Diabetes Mellitus. This is part 2. And let's talk about the symptoms. So initial signs is going to be number 1, increased thirst, which is your polydipsia, your increased urination, polyuria, and 3, increased hunger, polyphagia. The type 1 only has polydipsia and polyuria. Okay, the polyphagia is on diabetes type 2. Unintentional weight loss often occurs with type 1 diabetes and sometimes with advanced undiagnosed type 2. Additional signs include blurred vision, diabetes type 2, blurred vision, fatigue, dehydration, because the patient only way to eliminate the excessive glucose in the system is by urinating. Okay, so when the patient is going to urinate, is going to eliminate a lot of glucose. That's why dehydration, skin irritation or infection. Bacteria in our body, they love sugar to multiply. So that's why they are in risk for infection, and general weakness and loss of strength. Individuals with type 2 diabetes often do not recognize the signs because the symptoms develop gradually over many years. And please remember, that's good to know, skin infections and weakness are symptoms of diabetes, the initial symptoms, right? Laboratory tests. So these are going to show hyperglycemia, right, above 126. Abnormal glucose intolerant test also is going to be giving us bad, very high results. Elevated glycosylated hemoglobin A1C, that's your A1C test, and glucosuria, so glucose in the urine, right? So your A1C represents blood glucose levels over a 3-month period. Remember that some patients, they want to lie to the doctor. They love to lie. They said, hey, yeah, I followed my diet, everything is okay, this and that, and they do the diet and everything, and they bring the glucometer with the numbers from the results from the last 2 weeks. But since we have the A1C, we can easily recognize that the patient is lying, right? So he can be teaching us. He can show that the results for the last 2 weeks were optimum, but then when you see the A1C, there's no room for misdiagnosis. Okay, individuals with a H1C test within the range of 5.7 to 6.4% have intolerance glucose test and are in a very high risk for progressing to diabetes. A1C levels of 6.5 or more are indicative of diabetes mellitus. So that's good to know. Normal glucose levels fasting, in the fasting state, are between 70 and 100. So in the early morning, as soon as they wake up, it should be between 70 and 100. Or also after 2 hours of having the meal must be less than 180, the 2-hour postprandial, right, that I mentioned before. Okay, criteria for the diagnosis of diabetes mellitus. This is just for general information. The most important, I think, at this point for you to know is what are the normal levels and how high the glucose should be after 2 hours postprandial, right? So let's review some criteria. DCCT is diabetes control and complications. FPG is the fasting plasma glucose in the morning, right? OGTT is the oral glucose tolerance test, and the World Health Organization, the WHO, and 2-hour postprandial, the 2 hours plasma glucose, right? Criteria for the diagnosis: if your fasting plasma glucose is more than 126, so the patient woke up, right, in the morning, 7 in the morning, you take the glucose and is 126, is equivalent to 7. So fasting is defined as no caloric intake for at least 8 hours. So let's say the patient got crackers and milk like around 2 in the morning, and then you're gonna take the glucose at 6 in the morning. That is not fasting, because there is only 4 hours between the crackers and the glucose test, right? So the glucose monitoring test. So it has to be 8 hours, 8 hours, okay? So if you're taking the test at 7 in the morning, if you're measuring the glucose at 7 in the morning, last meal should be at 11, okay? Or, so we have the fasting is more than 126, no caloric intake for at least 8 hours, or 2 hours after meals, right? It should be more than 200. When it's more than 200, this test should be performed as described by the WHO, using a glucose load containing the equivalent of 75 gram antigraduous glucose dissolvent. Okay, whatever. So if it's more than 200, it's not normal. It has to be below 180. Okay, or the A1C when it's more than 6.5. That also is a criteria for the diagnosis. So it's either the fasting or, right, the 2-hour postprandial, or the A1C, or in a patient with classic symptoms of hyperglycemia or hyperglycemic crisis, a random plasma glucose of more than 200, which is equivalent to 11.1. So one thing is the equivalence of the glucose in numbers could be 126 milligrams per deciliter, or 7 or 11.1, right? Those numbers. And another thing is the percentage in the A1C. Okay, so now here is table 20, correlation between glycosylated hemoglobin 1 and estimated average glucose level, what I just mentioned before. So here you have, for example, the patient was having 126 milligrams per deciliter. In A1C is going to be equivalent to 6, right? And irregular, if we translate that to the MMOL, is going to be 7. Okay, now the next table, you see here, 298 is equivalent to A1C of 12, right? So then, okay, let's continue. Summary of glycemic recommendations for most adults with diabetes. And okay, so you have the parameter. The recommendation for A1C is to be below 7, okay? And the preprandial capillary plasma glucose level, it should be 80, okay, to 130. Preprandial 80 to 130. So these are recommendations with adults with diabetes. One thing is the patient that is a regular adult, should be 70 to 110. But with diabetes, in the preprandial, before meals, the levels are 80 to 130. Those are acceptable, right? And then, or below 7, below 7, below 7. And peak postprandial after eating, capillary plasma, 1 to 2 hours from the start of meal, it should be less than 180, okay? Less than 180. Okay, so let's keep moving. The metabolic pattern of diabetes, energy supply and control of blood glucose. So energy supply, we have 3 basic stages of normal glucose metabolism as follows for energy. So we have number 1, initial interchange with glycogen. And remember, glycogen is in the liver. So glycogenolysis and reduction to a smaller central compound, glycolysis pathway. So glycolate is going to break down. So glucose is going to be available in the system for energy, right? So for energy supply, remember that our intake of glucose is going to be stored somehow in the liver, and that is be called glycogen. Okay, and then in order for that glucose to be available, right, by the request of glucagon, which is secreted by the pancreas, so that glycogen is going to break down in different pieces, right? And is going to release glucose, and that process is called glycogenolysis because it's breaking down a compound. Number 2, joining with other 2 energy yielding nutrients, fat and protein, which is the pyruvate link. So then either is glycogenolysis or the pyruvate link, right? And then you have the final common energy production, the citric acid cycle and electron transport chain. So blood glucose management, how are you going to, and I have here a very interesting article from the Cleveland Clinic, but I think we already went over the difference between glucagon and glycogen. Glucagon is secreted by the pancreas and is going to request the liver to release the stored glucose, right? And glycogen is the stored glucose that is that acquires that name because this is the glucose stored in the liver. So then blood glucose management, optimal health depends on managing blood glucose level within recommended regions. Normal control mechanism ensures sufficient circulating blood glucose to meet the constant energy needs, even the basal metabolic energy needs during sleep. That's called basal metabolic needs, because glucose is the body's preferred fuel, especially for the brain and the red blood cells. So even when we are sleeping, we need a certain amount of, we need some energy, right, for our organs to process, especially the liver, our brain, our lungs, our heart, right? They need certain amount of energy to work. Sources of blood glucose are the dietary intake in the form of carbs, carbon backbones of fat and protein, and then glycogen, okay, the backup source from the constant turnover of stored glycogen in the liver. So we have those 2 sources of blood glucose, the dietary or the one that is stored in the liver as a glycogen. And I want you to remember something very important, that the hormone insulin is not related with the mobilization of liver glycogen to release. Okay, so insulin is not involved in that glycogen to be released by the liver. It's glucagon, the one that is involved. Okay, remember that. So uses of blood glucose, we are going to use it for burning it during cell oxidation for immediate energy needs. That is called glycolysis. And then we are going to use it for changing it into glycogen, glycogenesis. Genesis, we are going to create that big molecule called glycogen, and which is briefly stored in the muscles and the liver, and then converting it to fat, which is stored from longer periods in adipose tissues, and that is called lipogenesis. So any time that a new compound is going to be created, is going to be called genesis. So you have a compound based on lipids, is going to be lipogenesis. So if the compound is based on sugar, glucose, is going to be glycogenesis. Okay, so pancreatic hormone control, the specialized cells of the isolates of Langerhans in the pancreas provide 3 hormones that work together to regulate blood glucose levels, which is insulin, glucagon, and somatostatin. Okay, so that's good to know also. Somatostatin is synthesized by pancreatic delta cells, while most of the pancreatic beta cells are the one releasing insulin. Okay, so you have those 2 concepts. Okay, so the delta cells are secreting somatostatin, and the beta cells are releasing insulin. Okay, so then insulin is the major hormone that controls the level of blood glucose. It accomplishes this through the following metabolic actions. So helping to transport circulating glucose into cells, that's insulin, stimulating glycogenesis, the creation of the glycogen. Okay, so that's insulin. Dr. Matalana, I'm confused because you mentioned that insulin is not related to any process related to glycogen. Okay, first of all, glycogen is the glucose that is stored in muscles and livers, right? Number one. Number two, insulin is involved in the process of glycogenesis. So it's going to create that big compound glycogenesis. But glycogenide, oh, what is the name of this? I forgot. So the breakdown glycolysis, okay, is going to be done by glucagon. So please, liver, release that glucose in the form of glycogen you have stored there. So that's something different, glycolysis versus glycogenesis, okay? Also, insulin is going to be involved in stimulating lipogenesis. So it's basically involved in all the creations, inhibiting lipolysis and protein degradation, and also promoting the uptake of amino acids, right, by skeletal muscles, okay? And thereby increasing protein synthesis, okay? So permitting cells to burn glucose for constant energy as needed. Also, this is going to be one of the main actions in which insulin is going to be involved. Okay, so here we have a very nice graphic in which you can see the blood glucose levels, you know, from if the glucose levels is 20, the patient is going to be presenting convulsion. Now we go up. I'm reading the line that is in the middle, the red the red strip. So you have 70, and that's kind of normal range, yes, all the way to 120. And then you can see on the left side the glucose is going to be formed by carbohydrate intake, protein, fat. The protein is going to be participant in gluconeogenesis, and the fat in gluconeogenesis as well, with a 10% of participation. The liver glycogen is going to have 100 to 150 grams of storage, and that is glycogenolysis, right? So then on the right side, we can see the glucose that is going to be in the adipose tissues, in the muscle, and for energy. Okay, and if the glucose level goes all the way up to 170, it's going to be called glycosuria. So we're going to see glucose molecules in the urine. Okay, so I have to learn how to manage this because I'm not good in this. Okay, glucose metabolism, very interesting also diagram. Then you can really go and double check. And then we are going to talk about now about glucagon, okay? So glucagon is a hormone that acts in an opposite manner to that insulin to balance the overall blood glucose control. Hypoglycemia triggers a rapid breakdown of glycogen in the liver, and then this action raises blood glucose concentrations as needed to protect the brain and other tissues during sleep or fasting. Remember that we need enough glucose in the brain for our thinking, for our critical thinking, all the functions that the brain takes control in terms of movement, giving orders to the different endocrines. So we need really glucose in the brain for those actions to happen. Care providers may use glucagon injection as a quick acting antidote for a severe low blood glucose, especially if the affected individual is unresponsive. And I've seen this type of reactions. I saw a patient once with a glucose level 25, was really rigid, and when the glucose is that low, you put the patient at risk for seizures, right? So think about that. We need to achieve these levels and to put them under control for the safety of the patient. So here you have the pancreas, you have the pancreatic islets, and also you can see the graphic for the delta cell, the beta cell, the alpha cell, the blood vessel, right? It's very important that you get familiarized and you know your map, right? Let's move to the next topic. So this is going to be also the insulin allows glucose to enter the cell through the glucose channel. You can see here the different phases, right? And then let's talk about somatostatin. So we spoke about glucagon, insulin. We are still in the pancreas action related to the diabetes. So the somatostatin is a referee for several other hormones that affect blood glucose level. Somatostatin inhibits the secretion of insulin, glucagon, and other gastrointestinal hormones. So this hormone inhibits the secretion of insulin, glucagon, and other intestinal hormones because it has more generalized function in the regulation of circulating blood glucose levels, other parts of the body, and also produce somatostatin. So abnormal metabolism in diabetes with hyperglycemia. When insulin action is insufficient or deficient, abnormal metabolic changes and imbalances occur among the three macronutrients. So when we say macronutrients, we are talking about proteins, carbs, and lipids, right? And that's good to know. By definition, diabetes is related to the abnormal metabolism of carb, protein, and fat. Okay, by definition, diabetes is the abnormal metabolism of carbs, proteins, and fat. Okay, so let's talk about glucose. Unlike other areas of the body, the pancreatic cells do not need insulin for glucose transport. Normally, what happens after a meal or a snack is that that glucose is absorbed into the pancreatic cells and triggers the secretion of insulin into the bloodstream, right? So we eat, the pancreas know that glucose is going to be high, so that's why I'm releasing insulin to create a balance. The blood then circulates insulin throughout the body, attaching to insulin receptor sites on cell membranes throughout. Now, without adequate insulin, this process cannot happen, or if insulin resistance is present, this process occurs in a less efficient manner. So therefore, cells are essentially starving for glucose, the cells that does not have the insulin receptors, right? They are starving for glucose as glucose concentrations increase in the blood, resulting in hyperglycemia. Okay, so you need to understand that when the insulin attaches to the insulin receptors in the cells, what is going to happen is that they are going to allow the entrance of glucose into the cell, right? So if that is not happening, the glucose is going to remain in the blood, causing hyperglycemia. So fat. Insulin promotes lipogenesis and inhibits lipolysis. So in other words, promote the creation of lipo cells, compounds, and stops the breakdown of these lipo compounds, right? In the absence of functioning insulin, lipolysis in the adipose tissues increases in an effort to burn fatty acids for energy. So this release of fatty acids into the blood results in elevated triglyceride levels. So when these fatty acids are released, triglyceride levels increase. In addition, ketogenic ensures in the liver. The intermediate products of fat metabolism is called ketones. We know that, right? In type 1, this patient is going to be in diabetic ketoacidosis, right? And ketones accumulates in the body. So ketones are acids and their excess accumulation leads to DKA, diabetes ketoacidosis, DKA. It's a risk for individuals with type 1, but this rarely occurs on type 2. And that's good to know. Another thing I want you to remember is that ketones are the byproduct of the metabolism of fats. So when there is not enough glucose, carbs available for energy, then the body is going to look for the fat storage. And and it's going to break down, it's going to metabolize those compounds. Okay, protein in the absence of insulin, protein tissues are also broken down in the body's effort to secure energy sources. So the body is going to look for fat, it's going to look for protein storage, thereby causing weight loss, muscle weakness, and urinary nitrogen loss. So long-term complications of diabetes type 2, these health problems mainly relate to microvascular and macrovascular dysfunctions in the vital organs. So I want you also to remember, that's good to know, 3 common long-term complications of diabetes are going to be the ones affecting the kidneys, the eyes, and the nerves. Okay, kidney, eyes, and nerves. So now let's get into the more professional terminology, right? So retinopathy, those are the eyes. Retinopathy involves damage of the small blood vessels in the retina, increases with incessant hyperglycemia. So patients that are having high glucose levels out of control, they are going to have retinopathy. It's called diabetic retinopathy. Okay, examinations with dilation should continue from that point forward every 1 to 2 years for individuals who have had no evidence of retinopathy, and annually for individuals with retinopathy. So if the patient with diabetes is having hyperglycemia that is not controlled, but there is no evidence of retinopathy, then he can skip this test and do it every 2 years, right? But if there is a history, annual test must be done. Do not confuse retinopathy with the blurry vision that sometimes occurs as one of the first signs of diabetes. The increased glucose concentration in the fluids of the eye causes brief changes in the curved light refracting surface of the eye. That's why the patient with diabetes is having blurry vision. Glycemic management usually improves this form of temporary impaired vision. So nephropathy, which is the kidneys, right? Hyperglycemia also damages the small vessels within the kidneys. Diabetes is one of the leading causes of end-stage renal disease in the United States. So diabetes is one of the causes of the renal end-stage renal disease. So the presence of either albuminuria, which is a derivative from your protein, right, or decreased estimated glomerular filtration rate, your GFR, is diagnostic for diabetic kidney disease. Nephropathy and end-stage renal disease is incurable. This is incurable. So once the kidney starts developing this kidney disease, it's going to be a stage 1, stage 2, stage 3, okay? It's incurable. So however, with improved glucose management and antihypertensive therapy, disease progression can be slowed. Okay, annual follow-up in both groups is necessary. So remember that the functional units of the kidneys are the nephrons, and we need to take care of them. Now we have neuropathies, right? So remember the 3 common complications: long-term diabetes, the kidney, the eyes, and the nerves, right? So neuropathy indicates the highly sensitive nature of the small nerves throughout the body to chronic hyperglycemia. Damage to the nerves most commonly involves injury in the peripheral nervous system, especially in the legs and feet. That's the peripheral nervous system, legs and feet. The loss of nerve sensation can lead to further tissue damage and infection from unfelt foot injuries, such as bruises, burns, or deeper cellulitis. The patient with diabetes that are losing this nerve sensation, they don't know that they had a bruise down there, or the sensation of burn or cellulitis or pain, right? Because they don't feel it. So amputations and foot ulcerations are very common Because of diabetes, autonomic neuropathy also results in significant clinical concerns such as hypoglycemia unawareness, gastroparesis, orthostatic hypotension, erectile dysfunction, constipation or diarrhea, and bladder dysfunction. When we are talking about autonomic neuropathy, means all the functions that are done automatically. Okay, so we have our gastro is moving, our GI is moving automatically, our high blood pressure, constipation, diarrhea, that is the automatic function of the bladder and the colon, right? And then annual follow-up for both groups is required, right? For type 1 and type 2. Heart disease, cardiovascular disease is a major cause of death for people with diabetes, because think about it, they are going to be accumulating not only fat but also sugar, glucose in the arteries and veins, right? And their risk of death from heart attack or stroke is almost double that their other counterparts without diabetes. So blood lipid levels, blood pressure control, aspirin use, which is it helps with the anti-clotting, right? Lifestyle changes incorporating weight loss and smoking cessation. Glycemic control is not as strong related to macrovascular complication. So we need to work on the glucose control, right? So glycemic control is not strongly related to macrovascular complication like dyslipidemia or hypertension, as it to other long-term microvascular complication of diabetes like retinopathy, nephropathy, or neuropathy. So macrovascular is your cholesterol and hypertension in your veins and right arteries, and microvascular are those tiny little vessels. So you can have that in retinopathy because the vessels are very small, nephropathy, and neuropathy. However, the comorbid condition of hyperglycemia and dyslipidemia greatly increase the risk of cardiovascular disease. So then we have dyslipidemia, hypertension, elevated triglyceride levels and decreased high density protein, the HDL, which is your happy cholesterol, right? When they are decreased, are characteristic of dyslipidemia in patients with type 2. And the management of this is one, incorporating lifestyle modification to focus on reducing the saturated fats, which is nutritional approach, and avoidance of trans fat, increase intake of omega-3 fatty acids, fiber, and plant stenols, which is your vegetables, right? Your weight loss and increase physical activity. So number one is basically full nutrition. Number two is lowering low density protein cholesterol levels. And number three is lowering the triglyceride levels, right? So chapter 19 discusses dietary and lifestyle recommendations to improve lipid profiles for adults. And that's a good idea to go there and just take a look. Hypertension affects 73.6% of adults with diabetes. It's 73%. Okay, hypertension is a major risk factor for microvascular complications, meaning your eyes, your kidney, and your nerves, right? Hypertension and coronary vascular disease mortality is significantly higher for people with both diabetes and hypertension, right? So blood pressure evaluation and treatment is important to follow up. Okay, the goal in patients with diabetes is to be 130/80. That's the goal. Okay, that is really the goal, and it's achievable, right? Lifestyle modifications such as reducing sodium intake, losing weight. Again, weight is mentioned in every single part of this chapter. Weight loss, right? Increasing the consumption of fruits, vegetables, and low-fat dairy products, following the DASH diet, right? Moderating alcohol intake and increasing physical activity levels again. So now we are going to talk about general management of diabetes, early detection and monitoring. So it's important, the early detection of to prevent complications, and community screening programs and annual physical examinations are there. It's good to double check your A1C, and the test reflects the average level for glucose over the preceding 3 months. We know that. The basic goals of CARES is diabetes self-management education. Um, it cannot be done in one visit. When we educate patient in terms of diabetes, we have to teach the patient or basically all what we are learning here about the nutrients. It's a long conversation, multiple sessions. They need to know starchy vegetables, non-starchy vegetables, what are carbs, what are proteins, what are fats, how to read labels, what type of hormones are we dealing with. It takes time. So the education must be focused on really motivate the patient to learn. If not, sometimes invite the patient to cook, right? And to present with different recipes, right? Okay, because the diet is not a good format to follow. Like you give a written diet that he must follow: breakfast, 2 strawberries, lunch, 2 apples. It's not going to work like that. You need to provide the knowledge so the patient can be free for selection in any context. If the patient goes to a restaurant, if the patient is going to travel, if the patient has full control and full knowledge, is going to be able to make knowledgeable and assertive choices, right? Glycemic management and medication. This objective seeks to keep a person relatively free from symptoms of hyperglycemia and hypoglycemia, right? So we need to work on that. And then we were talking about individuals, right, that are having glycosuria, which indicate poor glycemic management. So that is one of the symptoms. And also pay attention to insulin injection, oral medications, healthy eating, regular physical activity, and glucose monitoring. Exogenous insulin, there is a type of insulin regimen that is called exogenous, right? So this action correlates to food intake and physical activity. So if the patient is having good food intake, good nutritional and good physical activity, probably is not going to need insulin. Okay, but if the glucose level is not controlled, insulin is gonna take place. Training in proper insulin injection techniques, storage, and timing. So we have to add this training on top of the previous training that I mentioned before, right? In addition to standard injections with needle and syringe, or insulin pen, insulin pumps, and can administer insulin. And on top of that, we need to teach the patient about glucose monitoring, how to use the glucometer. So it's a lot of teaching for this condition. It's a lot. That's why sometimes I would say a good quantity of patients, they are not having a good control in diabetes. Most of the patient diabetes is not well controlled. This is a disease that it takes a lot of effort, and not only from the patient and motivation, but also from the providers, the nursing team, the endocrine team management, right? Glucose, oral and non-insulin injectable medications. There are different types, and non-insulin injectable. There are different types, and they are using right now Ozempic, for example, to lose weight. But I've seen in the gastrointestinal clinic, many patients are developing the flash phase, and then they are having gastroparesis and problems with the gastrointestinal. They come to the clinic with bloating, a lot of bloating, irritable bowel syndrome, constipation, oh my God, you name it. So I strongly do not recommend really this type of injections. Now, let's see the types of insulin, because at the end, If these injections are for people that are really having a BMI of 40, 45, 50, that they can barely move. But if you can move, you can walk, you can do some exercise, and you can try to eat healthy meals, why not? Why you have to depend on this, right? So the types of insulin, we have the rapid acting used as bolus insulin. The onset is within 15 minutes, and then you have the short acting, immediately works after 30 to 60 minutes, right? And then you have intermediate acting, 1 to 2 hours. Long acting is 1 to 3 hours. The ultra long acting use is going to, the onset is going to be 1 to 6, right? And then we also have the premix intermediate acting and regular short acting, 30 to 60 minutes. And premix insulin Lipros, 10 to 15 minutes. So a good trick, for example, here to memorize this is that the onset of action is, every step is double the time. So you start with 15 minutes. The next one, the onset is going to be the short acting within 30, which is the double of 15. And then you have the intermediate is going to be the double of 30, which is 1 hour, right? To 2 hours. But it's good that you learn the first number. Then long acting is gonna be 1 to 3 hours. So the intermediate, the long acting, and the ultra long starts the onset in 1 hour. Okay, and then if is the ultra long acting, it's going to be 36 to 42 hours, almost 2 days present in the system, right? And basically that's it. And within time, with practice, you are going to be more familiarized with the names. So your Lantus is your basic long-acting Lantus long, right? Long-acting insulin. And that's easy to remember, right? And then your Humulin and your Novolin is your short-acting. And then these Tresiba are medications that are kind of new, ultra long acting. There are many side effects, right? That you are going to come across little by little with the practice, right? Whenever you do your clinicals. So now, for further focus, comparative types of insulin, right? This is for you to read. The most important, I would say, from this chapter is all the patient education, extensive patient education that we need to do, and get familiarized with your types of insulin, and very important also your levels for normal glucose, right? Optimal nutrition within the basic goals of care. The second objective is to maintain healthy eating patterns to support optimal health. And we need to lose weight, right? Here you have some pictures. You have your Novolog, right? Which is your, what type of insulin? Aha! We just reviewed that. Your Novolog, right? I mentioned two basic that you need to remember. Your Lantus, long Lantus, right? Your Novolog and your Humalog are going to be your, here, short acting insulin, right? Okay. So let's continue. So let's move. Here is a glucometer. Okay, we have more a small size of glucometer. Right now the technology is very good. So remember your physical activity. You have to perform at least 150 minutes per week of moderate intensity aerobic, which is 50 to 70% of maximum heart rate. Ideally, exercise bouts occur at least 3 days per week with no more than 2 consecutive days without exercise. So if you do exercise on Monday, you cannot wait to go back to exercise until Friday. It has to be Monday, maybe Wednesday, or every day, which is much better. and at least twice per week in the absence of contraindications. Regular, moderate, intensive exercise for type 1 and type 2 manage their blood glucose levels, and they reduce their risk for CVD, hyperlipidemia, hypertension, or obesity. Okay, and that's good to know. Basically, exercise, good nutrition, right? Diabetes self-management, education, and support. So here are some medications, non-insulin and oral injectable medications, but we're gonna stop here. Okay, we spoke about a lot about insulin and different organs and complications. When we come back, we are going to talk about the oral and non-insulin injectable medications. Remember, this is a long chapter, and this is one of the main diseases and conditions that in which healthcare in United States spend a lot of money. So this is going to be on your NCLEX, and every single patient, no matter what unit you work in, a hospital, in a community center, in a private office, every patient, I would say, you are gonna come across diabetes all the time, every day. So don't think about this chapter is very long. Just think about you need to master this, not only for your NCLEX, but for your future practice, okay? So when we come back, we're gonna talk about the oral and non-insulin injectable medication. Thank you.